In this video, we'll be discussing about diabetic retinopathy. Now, the definition. Now, diabetic retinopathy, DR in short, it refers to the retinal changes seen in patients with diabetes mellitus. Okay, so diabetic retinopathy, retinal changes seen in patients with diabetes mellitus. Now, coming to the etiology. Now, the etiological factors include duration of diabetes, the type of diabetes, sex, heredity, pregnancy, hypertension, obesity, smoking, and poor metabolic control. Now, of these, the most important risk factor is the duration of diabetes, and it is a duration of disease after the onset of puberty, that is, after the age of 12 to 13 years, that acts as a risk factor. Okay, so this is the duration of diabetes is the most important risk factor. Now, the type of diabetes, diabetic retinopathy, it is higher in type 1 compared to type 2, and it is more common in females than in males. So these are the etiological factors. Now, coming to the pathogenesis. The basic pathology is that hyperglycemia in uncontrolled diabetes mellitus, it produces microangiopathy, which affects the retinal precapillary arterioles and venules and the capillaries. So this is the basic pathology: hyperglycemia leading to microangiopathy which affects the retinal vessels. Now, hyperglycemia, it leads to microangiopathy by the following mechanisms. The first is cellular damage, that is, damage to the cells of the retina and endothelial cells due to sorbitol accumulation and excessive oxidative stress. Now, the second is hematological and biochemical changes, and these include increased platelet adhesiveness, increased blood viscosity, Rolex formation, and leukostasis. Okay. Now, microangiopathy, it produces diabetic retinopathy by the following effects. The first is breakdown of the blood retinal barrier. Second is weakened capillary walls. Now, this can lead to microaneurysms and hemorrhages. Now, the third is microvascular occlusion, which leads to ischemia, and ischemia of the retina leads to the infarct of the nerve fiber layer, and this can be seen as cotton wool spots. And two is the formation of arteriovenous shunts. So again, the pathogenesis, the basic pathology is that hyperglycemia produces microangiopathy, which affects the retinal precapillary arterioles, venules, and capillaries. Now, hyperglycemia produces angiopathy by cellular damage and hematological and biochemical changes. Now, cellular damage like sorbitol accumulation and excessive oxidative stress, and hematological and biochemical changes include increased platelet adhesiveness, increased blood viscosity, Rolex formation, and leukostasis. Now, microangiopathy leads to the microangiopathy affects the retinal precapillary vessels by the following effects. The first is the breakdown of the blood retinal barrier. Second is a weakened capillary wall due to destruction of the endothelial cells. This can lead to formation of microaneurysms and hemorrhages. And the third is microvascular occlusion, which leads to ischemia, and ischemia leads to the infarct of the nerve fiber layer of the retina and formation of arteriovenous shunts. So this is the pathogenesis. And the pathogenesis also involves neovascularization of the retina. Now, one of the features of diabetic retinopathy is the neovascularization, and this is caused by proangiogenic factors like vascular and endothelial growth factors or platelet derived growth factors, etc., which are released as a result of ischemia. And the second is due to deletion of anti-angiogenic factors like endostatin and angiostatin. Okay, so in diabetic retinopathy there is formation of new vessels, that is, there is neovascularization, and this is due to activity of the proangiogenic factors and due to deletion of the anti-angiogenic factors. Now, moving on to the classification of diabetic retinopathy. Now, it can be classified as number one, non-proliferative diabetic retinopathy, that is NPDR, non-proliferative diabetic retinopathy. The second is proliferative diabetic retinopathy. The third is diabetic maculopathy, and the fourth is advanced diabetic eye disease. So this is the classification. Now, non-proliferative diabetic retinopathy, it is again divided into mild NPDR, moderate NPDR, severe NPDR, and very severe NPDR. Now, let us look into each classification in detail. Now, beginning with the non-proliferative diabetic retinopathy. Now, the features of non-proliferative diabetic retinopathy, it includes retinal hemorrhages. Now, this can be seen as both deep and superficial hemorrhages, and this occurs due to capillary leakage. The second is hard exudates. Yellowish white waxy looking patches are commonly seen in the macular area. Third is dark blot hemorrhages. Now, these represent hemorrhagic retinal infarcts. The fourth is cotton wool spots. Now, these are the whitish, fluffy, superficial lesions, and they represent areas of nerve fiber infarcts. The fifth is venous abnormalities. These include beading, looping, dilation of the veins, which adjacent to the area of capillary non-perfusion. Sixth is intraretinal microvascular abnormalities, or IRMA. Now, these represent the arteriovenous shunts. Okay, we've discussed that because in the pathogenesis we discussed that due to microangiopathy there is formation of arteriovenous shunts and cotton wool spots. Okay, so this is the sixth feature, that is intraretinal microvascular abnormalities. Now, they are seen as fine irregular red lines connecting the arterioles with the venules. The seventh is microaneurysms. Now, these are formed due to outpouching of the capillary wall. Because the capillary wall is weakened, they are the earliest detectable lesions and are commonly seen in the macular area. And finally, there is retinal edema due to capillary leakage. So we have 8 important features. Now, a mnemonic to remember this is H.C. Verma made maths easy. Now, H.C. Verma is a book I used to study during my school days. So H.C. Verma made maths easy. So H stands for 3 things: retinal hemorrhages, dark blot hemorrhages, and hard exudates. Okay, H for retinal hemorrhages, hard exudates, and dark blot hemorrhages. Now, C for cotton wool spots. Now, they represent the areas of nerve fiber infarcts, and these are small whitish fluffy superficial lesions. So this is the fourth. Next is Verma. V for venous abnormalities like venous beading, venous looping, and dilation of the veins. IRMA stands for intraretinal microvascular abnormalities. Now, remember, these represent the arteriovenous shunts. Made maths easy. M for microaneurysms. Now, these are the earliest detectable lesions, and they are due to the outpouching of the capillary wall. And E for retinal edema. So, simple mnemonic, remember, H.C. Verma made maths easy. H3 for retinal hemorrhages, dark blot hemorrhages, and hard exudates. C for cotton wool spots. V for venous abnormalities like venous beading, venous looping, venous dilation of the veins. IRMA for intraretinal microvascular abnormalities, and they represent the arteriovenous shunts. M for microaneurysms, which are the earliest detectable lesions, and E for retinal edema. So here is a diagram to which depicts diabetic retinopathy. So the important features is hemorrhages, abnormal growth of vessels, which is actually a feature of the proliferative diabetic retinopathy. We'll come to that. Then we discussed aneurysms and cotton wool spots. Okay, and also hard exudates. So these are the features of non-proliferative diabetic retinopathy. Now, we also discussed that NPDR is again classified as mild, moderate, severe, and very severe. Now, the ETDRS classification of NPDR. Okay, early treatment diabetic retinopathy study classification of NPDR. Now, we discussed it is divided into mild, moderate, severe, and very severe. Now, let us look into the features that distinguish between these 4 classifications. Now, just note M. Verma. Okay, it's based on microaneurysm, venous abnormalities, and intraretinal microvascular abnormalities that we classify the NPDR. Okay, M. Verma. Now, for mild NPDR, there should be at least one microaneurysm present. Okay, so if at least one microaneurysm is present, we can classify it as mild NPDR. In moderate NPDR, microaneurysms or intraretinal hemorrhages in 2 or 3 quadrants, and there is early mild intraretinal microvascular abnormalities, and hard exudates or cotton wool spots may or may not be present. Okay, so when you're examining the retina, If microaneurysms or intraretinal hemorrhages are present in 2 or 3 quadrants, or there is mild intraretinal microvascular abnormalities, or along with the presence of hard exudates and or cotton wool spots, this can be classified as moderate NPDR. Now, severe and very severe NPDR, it is based on the 4-2-1 rule. Now, 4 means there should be 4 quadrants of microaneurysms and extensive intraretinal hemorrhages. That should 2 for 2 quadrants of venous bleeding, 1 for 1 quadrant for IRMA changes. Okay, so remember 4-2-1 rule. 4 areas of microaneurysms or extensive intraretinal hemorrhages, 2 areas of venous, 2 quadrants of venous abnormalities, and at least 1 quadrant of IRMA. So this is the 4-2-1 rule. Now, if any one of the 4-2-1 rule is satisfied, it is classified as severe NPDR, and if any two of the 4-2-1 rule is satisfied, it is classified as very severe NPDR. Okay, so this is the classification of further classification of NPDR. So remember, M Verma, M for microaneurysms, V for venous abnormalities, and IRMA for intraretinal microvascular abnormalities. Now, for mild, there should be at least 1 microaneurysm present. For moderate, there should be microaneurysms or 2 or 3 quadrants with mild IRMA. There can be presence of hard exudates or cotton wool spots. Now, in severe and very severe, we have 4-2-1 rule, and if any one of it is satisfied, is classified as severe diabetic retinopathy, and if 2 of the 4-2-1 rule is satisfied, it is known as very severe NPDR. Okay, so this is about NPDR, non-proliferative diabetic retinopathy. So remember the code HC Verma made maths easy. Okay, now moving on to the risk factors for progression of NPDR to proliferative diabetic retinopathy. Now, this includes the presence of intraretinal microvascular hemorrhages, microvascular abnormalities, multiple intraretinal hemorrhages, venous bleeding and looping, and widespread capillary non-perfusion areas. So these are the risk factors of progression of NPDR to PDR. Now let us discuss proliferative diabetic retinopathy. Now, PDR develops in more than 50% of the cases after 25 years of the onset of disease. Okay, so if a patient comes to you with history of having diabetes for more than 25 years, then you can think of proliferative diabetic retinopathy. Now, the hallmark of proliferative diabetic retinopathy is the presence of neovascularization over the changes of very severe NPDR. So, proliferative diabetic retinopathy, it is equal to neovascularization plus features of very severe NPDR. Now, features of very severe NPDR, remember 2 of the 4-2-1 rule, that is M Verma. Now, it is characterized by proliferation of new vessels from the capillaries. Now, this can occur in 2 forms. The first is neovascularization at the optic disc, abbreviated as NVD, and second is neovascularization elsewhere, abbreviated as NVE. So you can see in this diagram neovascularization at the optic disc and neovascularization elsewhere, so NVD and NVE. So remember, the hallmark of PDR is neovascularization plus features of very severe NPDR. Then other features include the formation of a fibrovascular epiretinal membrane. Now, this is formed due to the condensation of connective tissue around the new vessels. Then the third feature is vitreous detachment, and vitreous hemorrhage may occur in this stage. Now, proliferative diabetic retinopathy, it is again classified as early PDR and late PDR. Now, early PDR is PDR without the high risk characteristics, and late PDR is PDR with the high risk characteristics. So this is about proliferative diabetic retinopathy. So remember, it is equal to neovascularization plus very severe NPDR. Now, moving on to diabetic maculopathy. Now, changes in the macular region, it can occur in both NPDR and PDR. Now, ETDRS has coined the term clinically significant macular edema, or CSMO, clinically significant macular edema. Now it is diagnosed if one of the following are present on slit lamp examination. The first is thickening of the retina at or within 500 micrometer of the center of fovea. The second is hard exudates within 500 micrometer of the center of fovea, and third is development of a zone of retinal thickening 1 disc diameter or larger in size. Okay, so remember, CSMO, clinically significant macular edema, can be diagnosed if one of the following are present. The first is thickening of the retina, the second is hard exudates both within 500 micrometer of the fovea, and the third is a development of a zone of retinal thickening 1 disc diameter or larger in size. So you can see the first is retinal thickening within 500 microns, the second is hard exudates within 500 microns of the center of fovea, and the third is retinal thickening 1 disc diameter in size, part of which within 1 disc diameter of the center of fovea. So you can see in this diagram, so this is greater than 1 disc diameter in size, and it is a part of it is within the 1 disc diameter of the center of fovea. So these are the features of CSMO, clinically significant macular edema. Now coming to the clinico-angiographic classification of diabetic maculopathy. Now this in this diabetic maculopathy, it can be classified as focal exudative, diffuse exudative, ischemic and mixed. Now in focal exudative maculopathy, it is characterized by microaneurysms and hemorrhages and hard exudates and well circumscribed macular edema. Okay, so in focal exudative maculopathy, microaneurysms, hemorrhages, hard exudates are all present along with well circumscribed macular edema. Now the second is diffuse exudative maculopathy. Now it is characterized by diffuse retinal edema. Now the third is ischemic maculopathy. Now it is characterized by marked visual loss with microaneurysms, hemorrhages, mild or no macular edema and few hard exudates, and it occurs due to microvascular blockage. Remember, ischemia is ischemic maculopathy, that is due to microvascular blockage. And the fourth is mixed maculopathy, which has characteristics of both ischemic and exudative maculopathy. So this is about diabetic maculopathy. So remember, it can occur in both NPDR and PDR. Then we discussed two classifications: clinically significant macular edema and clinico-angiographic classification of diabetic maculopathy. Now in CSMO, we discussed the three criteria which should be present in slit lamp. If one of the three criteria, if present in slit lamp examination, can be diagnosed as clinically significant macular edema. The first is retinal thickening, and second is hard exudates within the 500 microns of the center of fovea, and the third is development of a zone of retinal thickening 1 disc diameter or larger in size, and a part of which is present within 1 disc diameter of the center of fovea. Now the clinical angiographic classification includes exudative and ischemic and mixed. Exudative is further classified as focal exudative and ischemic, focal exudative and diffuse exudative. Now finally, diabetic eye disease. Now it is the end result of uncontrolled proliferative diabetic retinopathy. Now the complications of this includes persistent vitreous hemorrhage, tractional retinal detachment and neovascular glaucoma. So these are the classification of diabetic retinopathy. So we discussed NPDR, second is PDR, third is diabetic maculopathy, and fourth is advanced diabetic eye disease. Now let us discuss the management of diabetic retinopathy. Now the management, it involves three things. The first is screening for diabetic retinopathy, the second is investigations, and the third is treatment. Now in screening, periodic follow-up should be done to prevent visual loss occurring due to diabetic retinopathy. Now once diagnosed with type 1 diabetes mellitus, the first examination is done after 3 years, and if you're diagnosed with type 2 diabetic mellitus, the first screening is done after 2 years. Now from there on, if mild NPDR is present, every year there should be an examination of the eye. If it's moderate, then every 6 months. If it's severe, then every 3 months, and if it's very severe, then every 2 months. So this is the screening. that is periodic follow-up to prevent visual loss occurring from diabetic retinopathy. The second is investigations. Now the investigations, it includes blood sugar estimation and HbA1c count. The second is urine examination. The third is renal function test. Fourth is lipid profiles. The fifth is hemogram, and the sixth is optical coherence tomography, or OCT in short. So these are the investigations to be done. Now coming to the treatment. Now the treatment modalities for diabetic retinopathy, it includes four things. The first is intravitreal anti VEGF drugs, that is vascular endothelial growth factor drugs. So treatment modalities, the first is intravitreal anti-VEGF drugs. Now the importance of this is, we discussed that neovascularization due to pro-angiogenic factors is a feature of diabetic retinopathy. So we give anti-VEGF drugs. The second is intravitreal steroids. The third is laser therapy, and the fourth, which is the final treatment, is surgery, that is pars plana vitrectomy. Now intravitreal anti-VEGF drugs, these include bevacizumab 1.25 milligram and ranibizumab. Okay, so izumab, bevacizumab and ranibizumab. So these are the intravitreal anti-VEGF drugs. Now these drugs are preferred over laser therapy in patients with focal exudative macular edema and diffuse macular edema. The disadvantages of these drugs is that it is very expensive and there is a risk for endophthalmitis. So this is the first, intravitreal anti-VEGF drugs. Remember, bevacizumab and ranibizumab. The second is intravitreal steroids. Now the usually given drug is intravitreal triamcinolone acetonide, or IVTA in short. So intravitreal triamcinolone acetonide. Now the disadvantages is that short duration, that is you have to give this medication every 2 months. The second is there is a risk for glaucoma, risk for steroid induced cataract, and risk for endophthalmitis. Now intravitreal dexamethasone slow releasing implant, or also known as Ozurdex. Now it can also be used over IVTA because of its longer duration of action. So we discussed intravitreal anti-VEGF drugs, bevacizumab and ranibizumab. Then we discussed intravitreal steroids like intravitreal triamcinolone acetonide and intravitreal dexamethasone slow release implant. The third is laser therapy. Now laser therapy is performed using the double frequency argon green laser. It is of two types, macular photocoagulation and panretinal photocoagulation. Now for focal diabetic macular edema, we use focal laser, a technique called focal laser, and for diffuse diabetic macular edema we use grid lasers. So this is about laser therapy. So remember, macular photocoagulation and panretinal photocoagulation. And the fourth is surgical treatment. Now the treatment of choice is pars plana vitrectomy, PPV with removal of the posterior hyaloid. Okay, so the surgical treatment is pars plana vitrectomy with removal of posterior hyaloid. So again, in the management we discussed anti-VEGF drugs, intravitreal anti-VEGF drugs, intravitreal steroids, laser therapy, and surgical treatment. Now the intravitreal anti-vascular endothelial growth factor drugs are bevacizumab and ranibizumab. Now the intravitreal steroids are the intravitreal triamcinolone acetonide, IVTA, or intravitreal dexamethasone slow releasing implant. Then we discuss laser therapy, which includes macular photocoagulation and panretinal photocoagulation. And finally we discuss surgical treatment, and the treatment of choice is pars plana vitrectomy with removal of posterior hyaloid. Now this ends our discussion on diabetic retinopathy. We discussed the definition, the risk factors, the pathogenesis. Remember, hyperglycemia leading to microangiopathy, and microangiopathy leads to the clinical effects. Then we discuss the classification as NPDR, which is further classified as mild, moderate, severe, and very severe. And the code to remember the features is HC, Verma, made maths easy. Then we discuss PDR, which is basically very severe NPDR plus neovascularization. Then we discussed diabetic macular edema, but we discussed diabetic maculopathy, where we discussed the ETDRS classification, that is clinically significant macular edema, and the clinico-angiographic classification, that is exudative, ischemic, and mixed. Under exudative, we have focal exudative and diffuse exudative. Then we discussed the management. Now, under management, we discussed the screening for diabetic retinopathy, the investigations to be done, and the treatment. So this concludes our discussion on diabetic retinopathy.